This is chapter 6, lifting and moving patients. I'm sure that you probably heard or have read somewhere that probably the number one reason why EMS and fire personnel wind up ending their careers is usually because of some type of lifting or moving injury to their back or their hips or even their knees. So it's really important that we make sure that we protect ourselves when we are moving patients around to and from the hospital. I'll give you a couple scenarios. So scenario number one is you have this gentleman sitting on the sofa. He's approximately 400 pounds, and you walk in the door. He calls because he's really weak today. He can't get up off the sofa like he normally can. You get to his apartment, you knock on the door, you go in, you see this approximately 400-pound patient on the sofa, and he says he can't walk. So then you know immediately, common sense would say you need help. And this is why obese people, we usually don't get hurt with these people because they're just a slam dunk. We know that these people are heavy. We know that two people can't lift this person safely anyway. And we need more help, essentially. On the other hand, you have this lady right here. She's fallen. She's lying on the ground in the convalescent home or in her private residence. She's broken her hip, so she has to go to the hospital. And she weighs all of 100 pounds. It's dripping wet, basically. And the problem with this is that we have a tendency to discount this as a potential injury problem for us. So we drop our guard, we lift and we move, and we twist and we turn, and we wind up injuring ourselves. And it's these lightweight people that we seem to get injured on. And of course, this can also happen. It's not just one event that can cause our back to go out, though that does happen sometimes. But it can also happen through this repetitive use, constantly lifting and moving, constantly using poor body mechanics and all that. So it's really important to keep your guard up at all times, protect yourself, and of course your crew members as well. So I'm sure you guys have already learned about seeing size up, talked about the number of patients and all that. What you can add into this, of course, now is the weight of the patient, the location of the patient. Is the patient entrapped in some way? Are they stuck behind their sofa? Are they trapped in a back bedroom of an RV? Are they stuck in a car somewhere? So this all adds complexities to our lifting and moving these patients because it's not a regular roll, just lift, and load kind of situation. You have to look at your physical abilities. Are you able to lift these people with what you have available with you? And if you don't, then you should immediately call for additional resources, including different types of equipment, some of which you've already learned about, things like gurneys and stair chairs and things like that. And I'll review that here today. Now, I'm sure some of you have taken classes on lifting and moving. Maybe you worked at a retail establishment. I worked at a Home Depot or something like that, or maybe you were in the military and they taught you the basics of safe body mechanics. It's really important that we follow these, generally speaking, but the problem that we run into in the field, in EMS, is when we go into these people's private residence or to a car accident or some type of wilderness event, we can't always use these four basic principles. We can't keep our back straight. We can't lift with our legs. The people are trapped in things. We have to twist. We have to move. We have to even contort ourselves a little bit to get into these tight spaces, and it doesn't allow us to follow these four basic safety tips for saving our back, basically. So I'm sure you heard about stacking. Stacking is you're standing straight, your shoulders and head's on top of the shoulders, shoulders are on top of the waist, and you bend at the knees, keep your back straight. You can see also that these two EMTs, their bodies are really close to the ends of the gurneys. So you want that weight as close as possible to your body. So you're not reaching out to lift something. You want to keep that weight as close as possible to your torso. And if you have someone entrapped in a really tight situation, then you're going to want to move them in these small increments. Get them straightened out. Maybe that's your first move, and then maybe move them a foot or so in one direction and then 2 feet in the other direction. And you take these little small moves to get this person out rather than one large move that might hurt yourself or even the patient. And when you are lifting something heavy like a gurney, you want to incorporate your abdominal muscles, your upper back muscles, your leg muscles, your arm muscles, and these all help support your lower back because the lower back takes the majority of the load on these lifts. And this is why we run into these chronic problems like ruptured discs and other issues that we have with our backs in EMS. Now, the power lift is probably the most common lift that we use out there. You can see from just this picture right here, the legs are about shoulder width apart. The toes are splayed out at about a 45-degree angle. Their backs are straight as they possibly can be. Their arms are straight, and they're lifting with their legs, not their arms. Also, you'll notice how they're making just great eye contact. Because you're going to be lifting this patient, you want to make sure that you're lifting at the same rate and at the same speed so that there isn't any kind of conflict in this lift causing one person to get their back injured. So a lot of this is a communication issue. If this person weighed more than what you see here, if he or she were 300 or 400 pounds, I would definitely think about 4 people on that gurney to lift rather than the 2 people you see here. Once the patient's loaded on the gurney, once they're lifted up into that loading position like you see here, to be loaded into the ambulance, the person in the front, that's the person at the foot of the gurney there, and we always try to lead the gurney with the patient feet first. That way it feels less uncomfortable for the patient whenever we try to, whenever possible anyway. The person in front at the feet, they're guiding the gurney, generally speaking, and the person in back at the head is pushing the gurney. And I know it's tempting to lean forward and straighten lock your arms and kind of push like you're pushing a sled up a hill, but that puts all that weight on your lower back. So keep your body straight and kind of push off with your legs, bend your knees and push off with your legs like you're sledding up a hill or something, like you're skiing up a hill possibly, especially if you're going up some type of fairly steep driveway. Now, there's various types of moves that your book talks about. The first one is an emergency move, and this is just that. The house is on fire, the car is going to explode, there's an active shooter, something has to be done right this very second to move this person from this area to an area of safety where they can be taken care of. So when it comes to this, we're not worried about spinal motion restriction. We're not worried about bleeding control. We're not really worried about airway right now. It's just getting them out of that area so we can work on them. And of course, your safety as well. So you can get body lifts and body drags and blanket drags and all different kinds of ways. You can throw them over your shoulder and do a fireman lift if you want, whatever works for you. The idea is to grab the patient and run for it. Now, a less emergent move is called the urgent move. And this is the patient who the scene is safe, somewhat anyway. The patient is unstable. Maybe they have a breathing problem. Maybe we have a bleeding problem that we can't get to because they're in this vehicle. Maybe you heard this woman's lower leg is amputated and she's squirting blood. And the only way to get to that leg is to get her out of that car. So we're going to put a collar on her neck if she needs it, and we're going to slide her out of that car and treat her on the ground next to the car. So again, this is a coordinated move. We do take into account things like spinal motion restriction. We do take into account bleeding control and airway. But if we cannot access the patient to perform those treatments, then they have to come out and then be treated once they've been freed from the entrapment. Now, non-urgent moves are probably the most common types of moves you'll be doing. Again, this is a non-urgent body lift. You see that these two gentlemen are lifting the lady probably up onto the gurney more than likely, or maybe up onto the sofa possibly. And if it's done correctly, it's quite safe for the patient as well as the crew. These two young ladies here, they're doing a drag or a sheet move. So they're sheeting the patient. This patient is lying on a hospital sheet, and they're using that sheet to slide the person from the hospital bed to their gurney. This is probably the most common way as an EMT you'll be moving patients, is using this sheeting method. And of course, you can have people stand up and walk and sit on your gurney, and if it's appropriate, if the person doesn't have any chest pain or any reason why they cannot walk, then there's no reason why the patient can't walk to your ambulance, walk to your gurney, whatever is appropriate for their situation and your safety. Now, gurneys themselves will have a lab, so you guys can practice with gurneys. So there's various types of gurneys out there. These are all ambulance gurneys. They all fold and fit into the ambulance. On average, these gurneys weigh between 100 and 150 pounds, ready to operate. If you add a 300-pound patient to this gurney, you're technically lifting about 450 pounds or so. So you can see where this can get kind of complicated and dangerous. There's various types out there. There's a manual gurney, which means you lift and lower this thing manually, like using your legs. There are power models out there, which are becoming more and more popular because they have a hydraulic motor in there, and it lifts and lowers the gurney through this hydraulic process. It doesn't load the patient into the ambulance. There are models that do that, but generally speaking, those are pretty rare. But at some point, you probably will have to lift this person into the ambulance, even if you do have a power gurney, at least here in the county of San Diego anyway. Now, for patients who are obese, or morbidly obese anyway, they do have what's called bariatric gurneys. Now, a regular gurney, like what we just previously saw, those are rated between about 400 to 600 pounds. So that's your max load capacity on these other gurneys. On these bariatric gurneys, I've seen them anywhere from 1,000 to 1,500 pound load capacity. These are heavy, they're wider, and because they're wider, they usually require a different ambulance, an ambulance that's set up for a wider bariatric gurney and thereby a wider patient. So if you do have a patient who's 600, 700, 800, 900 pounds, which I've seen those patients myself in the field, you're going to request a bariatric gurney. This is the same thing as you're doing your scene size up and you're checking for number of patients and was this an MOI? You're going to call for additional resources. So just like calling the fire department or calling the police department or calling whatever resource you want, this is just another resource you might want to call for. It takes a little while for them to get there, so you might want to call early. Now, stair chairs are another great resource for us. You can think of these as folding, very expensive folding wheelchairs. They do fold up flat. They fit in your ambulance. There's different types out there. The one on the left, the blue one, that has, you can see it has like a little track mechanism in the back. And that track mechanism, once it's deployed out at a 45-degree angle, as you're going down the flight of stairs, the tracks rest on the stairs and you push the stair chair down the stairs rather than carrying it. It's really good for us. It's really safe. The older version that you see on the right, the red one, that one you need to lift and actually carry down the stairs. So it's a little more problematic for us, but it's great for confined spaces. It's great for back bedrooms. Obviously, someone lives on a third floor or second floor, you can carry them down. The person has to be awake, alert, and cooperative. There really should not be any spinal motion restriction issues. If this person's having a massive stroke and they can't hold themselves up, they're listing grossly over to the side and they can't keep themselves upright, then it would not be appropriate for this patient. Anyone unconscious, of course, not appropriate for this type of patient as well. This is the wake alert medical patient or wake alert traumatic injury patient who can hold themselves up and is, again, not combative. Now, you've already had experience using long backboards. These are the plastic spine boards. We use these for spinal motion restriction. We use them for CPR. We use them for lifting and moving patients out of entrapments that might not even need spinal motion restriction, but we use the board as just a lifting tool. It makes it easier to lift the patient with all those hand holds and multiple crew members on that lift. The Ked Sled. So the Ked Sled, the Kedrick extrication device, was invented at the El Cajon Speedway back in the 70s, I believe it was. And essentially, it was designed to extricate race car drivers from the crashed automobiles. It's they call it an extrication vest. So this wraps around the person's torso, and the upper flaps wrap around the head, and the person has a cervical collar in place. Once all these straps are properly placed and tightened, and once everything's ready to go, this person technically, even though they're in a seating position, they are in spinal motion restriction. The patient is then lifted out of the vehicle using this vest, and they're placed on a long spine board and then transported to the hospital. Vacuum stretchers, they are not so popular. They're out there. The problem with vacuum stretchers is, one, they're really expensive. What happens with these is they roll out flat like a flat balloon essentially, and then you lay the person on the device and you pump out the air and you create a vacuum, and what it does, it folds around the patient and it contours to the patient's body, keeping them rigid like they're in spinal motion restriction. Two problems. One, they're really expensive, like a couple $1,000s a piece versus a couple $100s a piece for a spine board. And they do leak, and they can leak. So if you have a small pin leak somewhere, pinhole leak, these can gradually lose that vacuum and lose that form, and then you've lost spinal motion restriction. So you probably won't see too many of these out in the field, at least here in California anyway. Scoop stretchers. So scoop stretchers work really well for everything. I use them for spinal motion restriction, for hip fractures, CPR. Anytime we have to move a patient, a stroke patient that they cannot walk, especially down a flight of stairs, whether they need C-spine or not, scoop stretchers are a great device. You can see from the picture what happens. The two sides split apart. The shape of the scoop itself is kind of convex. So it has a little kind of a scoopy effect to it. And like in the picture here, you see this young man has fallen and broken his hip. So the crews don't even have to move this person from that position. It can leave him right in that lateral position and scoop him up, lift him up, place him on the gurney in that exact position, remove the scoop from out from underneath him by splitting it apart again. And the patient's been moved with very little movement and very little aggravation to his injury. But again, I use these for CPRs, and as of about 5 years ago, these are now acceptable if someone's having a spinal injury. In fact, I prefer it personally if I have a patient who has obvious neurodeficits. This person's fallen from a scaffolding or was hit by a car, and they have paralysis below the waist, or they can't feel their feet, or whatever it might be. This person has an obvious spinal cord injury. I don't want to log roll this guy. I don't want to aggravate his injury. So I'm just going to scoop him up using this device, and I'm going to lay him on the gurney with his collar in place and take him to the hospital exactly like that. So I'm not aggravating anything, and I'm not making the pain increase. Or the patient's discomfort increase. Stokes baskets. You'll see these on helicopters. You'll see these on rescue vehicles. These are designed to go over the side or be dropped by helicopters, or should I say lowered by helicopters, I guess. The patient's placed inside, and a person on a spine board fits right inside this basket. So you can put a person on a spine board, secure them with the collar and the straps, place them inside this, strap the person into this, and this can be carried out through a rough terrain. It can be lifted out by helicopter or by some type of some kind of crane device. They're very popular. I know lifeguards carry these. Usually the supervisor rigs usually have these, and pretty much all the fire departments will have access to Stokes baskets. Work really, really well. So finally, once you have this person out of their entrapment, and you want to get them to the hospital, which of course is our ultimate, idea here. We want to get them moving towards the hospital. That's the purpose of this whole process. We want to position the patient on the gurney in whatever position that you think is, the correct position or the patient's comfort. So if someone who has an altered mental status or has had a stroke, and they have paralysis due to the stroke, or they're confused, or they have overdose on drugs or alcohol, you probably want to put them on their lateral side, like you see in the upper picture. It could be the right lateral or left lateral, whatever is appropriate for the patient. That way, if they do have secretions in their mouth, then if they do vomit, it's more easily controlled and less likely to be aspirated into their lungs. Person's having chest pain, shortness of breath, dizziness, I don't feel good today, I stubbed my toe, those kinds of calls. This person's awake and alert. They can answer questions, whether they're confused or not, they can answer questions, and they're probably going to want to be in that Fowler position. I'm sure you learned about Fowlers. We talked about Fowlers back in the anatomy and physiology lectures, and we know about semi-Fowler and high Fowler, and so more than likely, this is called position of comfort. You're gonna set this person on your gurney, on their back, like you see in this picture on the lower left, and you're gonna ask the person, would you like to sit up more? Would you like to lay back more? Someone who's dizzy might want to lay back a little more. Someone who's short of breath might want to sit up further. Depends on the circumstances. And that's why we call it position of comfort, because it's the patient's really dictating their comfort level. And then finally, the little old lady who's being strapped in incorrectly on the gurney. Little old ladies, little old men, they're on a lot of medications. And between the aging process and all these medications they take, their skin gets really thin and really, really easily torn. It's like almost like parchment thin paper type of skin. So when we load a person like this onto our gurney, we want to make sure that those straps are not touching bare skin. You'll notice on there's that D tank sitting between her legs. That's a metal tank. If the edges of the regulator caught her ankle or caught her calf, it would tear her skin. You see the strap over her arms? If she had this paper thin parchment skin, it would she'd just tear that area right there. So pad these people really, really well. Put blankets over them or some kind of covering so the straps go over the covering, not the patient's bare skin. Otherwise, it's pretty much same thing you do with anyone else. So we're done with chapter 6.